Hello, thank you for attending the Philadelphia International Medicine lecture series. My name is Dr. Todd Lewis. I am the brain injury clinical specialist with a specialty in neuropsych from McGee Rehabilitation Hospital, part of the Jefferson Health System in Philadelphia, Pennsylvania. Appreciate you all coming today to listen to a lecture on understanding traumatic brain injury 101. We're going to talk about a basic brain injury at this time. So some of the things we're going to discuss today in relation to traumatic brain injuries are reviewing some of the epidemiology of traumatic brain injury and how it impacts recovery, gain a basic understanding of the mechanisms of traumatic brain injury, discuss some of the theories on the recovery of brain function, and explore factors that may influence the prognosis following a traumatic brain injury. We'll talk about some of the outcomes and a little bit about the theory of pharmacological intervention in the management of traumatic brain injury. My primary role at McGee Rehabilitation is addressing the neurocognitive and neurobehavioral sequelae associated with traumatic brain injury. So if you look at some of the incidents, in the United States, there are approximately 2.8 million, just under 3 million new traumatic brain injuries which occur each year. So I like to always kind of take a look at that because I think, unfortunately, brain injury, traumatic brain injuries are not in the spotlight quite as much in the United States and around the world. If we look at, and in no way trying to underscore the importance of these other diseases, illnesses, and injuries, but if we compare the number of new traumatic brain injuries each year in the United States to that of new cases of diagnosed multiple sclerosis, spinal cord injury, HIV, AIDS, and breast cancer, those numbers, while still very significant and need to be addressed, excuse me, pale in comparison to the number of traumatic brain injuries that occur each year. There has been a lot more in the news and a lot more research occurring given our increased understanding of concussions, but we're going to talk more about more significant traumatic brain injuries today. So worldwide, there are over 10 million traumatic brain injuries that occur each year, and it's hard to know how accurate those numbers are. My educated guess would be that those numbers are quite significantly higher, though difficult to track around the world, because even in the United States, it's difficult in that many traumatic brain injuries go either undiagnosed or unreported. So in countries that may be underdeveloped and have less in the way of sophisticated healthcare, it's likely that those types of injuries are not always being reported or reported accurately. So who is injured? If we look at the numbers from the United States, males are 1.5 times more likely to sustain a traumatic brain injury. As I say, it's I think, speaking as a male, that we tend not to be quite as intelligent as the other gender, and put ourselves in more risk-taking behaviors, resulting in traumatic brain injuries more frequently. The groups that are at greater risk, those children between the ages of 0 and 4, 15 to 19-year-olds, and over the age of 75. If we look at the numbers, we look at the ages, the leading cause of death and disability among children and young adults is traumatic brain injury. Again, in the United States, approximately 50,000 individuals will die each year due to a traumatic brain injury, with almost 300,000 individuals being hospitalized due to new traumatic brain injuries. Estimates are just over 1 million individuals treated and released given traumatic brain trauma. And as mentioned a little earlier, it's difficult, even within the United States, to have good information collected on a regular basis on traumatic brain injury. So it's difficult to have all of the specific incidents worldwide. In the United States, over 5 million individuals are living in the US with a traumatic brain injury, which breaks down to greater than 4,000 new traumatic brain injuries each day, leading to traumatic brain injuries occurring every 21 seconds in the United States. Again, underscoring the significance of traumatic brain injury and how often they occur and the devastation that they can lead to for the individual and their family and friends. In Canada, traumatic brain injury occurs every 3 minutes. So some of the leading causes of traumatic brain injuries depends on a few different things if we look at it from a worldwide perspective. And also, if we look at it, we can break it down by societal issues, we can break it down by urban versus suburban, but in general, falls are the leading cause of traumatic brain injury. If we think back to a few minutes ago, we were talking about the fact that age ranges 0 to 4-year-olds and over 75-year-olds. And if you think about that, clearly those are age ranges where falls are going to occur at a more frequent rate. So falls account for 47% of all emergency department visits and deaths. 0 to 14-year-olds, 54% of emergency department visits and deaths were due to falls. And then 65-plus-year-olds, 79% of emergency room visits and deaths were due to falls. Some of the other leading causes of injury. Second leading cause of traumatic brain injury is being struck by or against an object. So, for example, from a fall and striking the head on the ground, car accident, striking the head on the windshield, being struck by a moving object. Third leading cause of traumatic brain injury is a motor vehicle accident, and the second leading cause of death in the United States, sadly, is an intentional harm secondary to gunshot wounds. In Pennsylvania, where I am located, there are over 10,500 individuals hospitalized each year due to traumatic brain injury. Over 2,000 individuals die as a result of a traumatic brain injury. Over 50,000 are seen in the emergency department secondary to TBI, and over 26,000 children suffer a new traumatic brain injury. I'm just trying to highlight some of the statistics and data, again, based in the United States and local surrounding states from where I work and see many of my patients. In Maryland, located close to Philadelphia, and Pennsylvania, over almost 44,000 traumatic brain injuries occurred in Maryland alone in 2013, equating to approximately 120 new traumatic brain injuries per day. The number one cause of traumatic brain injury related deaths in Maryland were due to firearms. And the annual cost for traumatic brain injury for Maryland is well over $500 million a year. So as we see, unfortunately, deaths related to firearms, self-inflicted or otherwise, sadly has been on the rise. In Virginia, 28,000 new brain injuries occur each year. The leading cause of death were due, again, secondary to firearms between 2010 and 2014, and approximately 1,600 related deaths in 2014 were related to gunshot wounds. Importantly, for the United States, Virginia was the first state to have a brain injury registry. And as mentioned earlier, that's a very important way to track the significance of how often traumatic brain injuries occur, and also assists in conducting research on traumatic brain injury, how to prevent it, how to treat it, etc. Virginia Brain Injury Central Registry was established in 1984, and all Virginia hospitals are required to report traumatic brain injuries to the registry. So again, it's something that would be beneficial and helpful worldwide, because this is a worldwide epidemic, and something that we need to address in order to reduce the number of traumatic brain injuries that occur and also enhance the rehabilitation of individuals who suffer a traumatic brain injury. So by basic definition, a traumatic brain injury is a physiological disruption of brain function secondary to a traumatic event resulting in at least one of the following. So any period of loss of consciousness would qualify as being distinguished and reported as a traumatic brain injury. Any period of antegrade or retrograde amnesia. So that's a period of time immediately prior to and immediately following the traumatic injury, which impacts the individual's ability to record new memories. Antegrade and retrograde amnesia can be anywhere from a few seconds to minutes to hours to days, weeks, and months. Any altered state of consciousness would qualify as a traumatic brain injury, and any focal neurological deficits that may or may not be temporary. So if we break it down, mild traumatic brain injuries are defined as a loss of consciousness of less than 30 minutes. After 30 minutes, the Glasgow Coma Scale score is greater than 13, and post-traumatic amnesia is less than 24 hours. Post-traumatic amnesia, or PTA, is the period of time following the trauma in which individuals may be disoriented, are experiencing difficulty tracking information from day to day, and that's how we monitor post-traumatic amnesia, is when is an individual able to track information. What we often see, especially with a more mild traumatic brain injury, are individuals may appear lucid, they may be partially or fully oriented, and yet they're not tracking that information. They'll have no recollection of that later on. So we follow post-traumatic amnesia as one of the criteria not only for diagnosing a traumatic brain injury, but also addressing the possible prognosis of the injury. So more moderate to severe traumatic brain injuries, loss of consciousness is greater than 30 minutes. Post-traumatic amnesia is greater than 24 hours. And the Glasgow Coma Scale score is less than 13. So specifically for the Glasgow Coma Scale score, GCS, moderate traumatic brain injury is a score of 9 to 12, while severe injury is less than 8. And if we remember, the Glasgow Coma Scale score ranges from 3 to 15, and statistically speaking, the lower the number, the less likely of positive outcomes and recovery. So what types of traumatic brain injuries are there? There's closed head injuries, in which the dura mater is not penetrated. Open head injuries, where the head is struck from outside with an object penetrating the dura mater. And penetrating head injuries, knife, bullet, other objects penetrating the brain itself. So the primary injury that occurs at the time of a traumatic brain injury is a brain injury directly resulting from a trauma. There are contusions and lacerations of the brain surface, and we may often see diffuse axonal injury as well, with diffuse vascular injury and often multiple petechial hemorrhages and cranial nerve damage. Diffuse axonal injury occurs when the axons are stretched to a point of being damaged and injured, and possibly even breaking at a point. What occurs is with the force during a traumatic brain injury, there's rotational forces, and the gray matter, being heavier and denser, often will pull away from the white matter, which is less dense, and you have the stretching and breaking of axons. Intracranial hemorrhages, again, is a sign of traumatic brain injury, and we'll talk a little more specifically about what some of the resultant physical, neurocognitive, and behavioral injuries are associated with things such as hemorrhaging within the brain. Secondary brain trauma damage typically occurs is when damage occurs after the initial trauma. Most secondary injury occurs within the first 12 to 24 hours after initial injury, and thus the reason it's of utmost importance to monitor an individual because this may be preventable with edema, additional bleeds, hypoxia, anoxia, etc. And we also look at the penumbra or the tissue surrounding the primary injury as secondary trauma as well, and secondary injury that we need to attend to. Assessing traumatic brain injury and the acute intervention may include CAT scans, MRI scans, as we talked about just a second ago, monitoring the intracranial pressure to assist in preventing secondary injury, and then neurosurgical interventions as necessary. So those are some of the very basic assessment and interventions. There are many other interventions as well in attempting to keep swelling down and secondary injuries from occurring. So the symptoms that we look at for the traumatic brain injury is really dependent upon a number of different things. So the severity of the injury itself, the areas of brain which are impacted from the trauma, as well as what we were just mentioning, secondary trauma. So the brain itself, as I describe it, is localized in a very generalized way. So the way I kind of try and describe that to individuals, especially to families when they have a loved one that suffered a traumatic brain injury, is that there are specific regions of the brain, excuse me, which are responsible for more specific functions. For example, the left hemisphere, the left frontal area responsible for expressive language, just posterior to that, Wernicke's area responsible for comprehension of language. So there are areas such as that that are localized to more specific functions. However, the brain works as a global unit. So one may have an injury to the executor of the brain, the frontal lobes, and in that case still result in language difficulties, memory difficulties, etc., though there are more specific areas which have more specific relation to certain functions. My analogy would be that of an orchestra, is that each individual instrument is equivalent in some ways to those specific brain regions that are responsible for specific functions. But if every instrument, every artist played their instrument on their own, we'd have chaos. So while there are localized instruments, they need to work in conjunction with one another in a global way in order to create music. So the brain is very similar in that, with areas which are more specifically localized to certain functions, but the brain has to work as a whole in order to have a fully functioning individual from a neurocognitive and neurobehavioral standpoint. So we're not going to talk much about the specific lobes. I think most people are familiar with all of those, and some more of the specific functions which are associated with them. But again, recognizing that the brain must work in a very global way. So some of the impairments which we look at to address in traumatic brain injury from a rehabilitation standpoint: neurocognitive issues, which can include things such as basic levels of arousal, basic levels of attention, more advanced types of attention like divided and alternating attention, basic functions as focus and sustained attention, concentration, executive functions, judgment, planning, organization, etc. So it really depends, again, on the level of the individual when they arrive to rehabilitation as to what types of things we're going to start at and what we're going to look at in moving forward in trying to address these sequelae associated with the traumatic brain injury. We also look at the affective and neurobehavioral aspects of traumatic brain injury, which can include many different things, such as from the extreme of being apathetic to being impulsive and unsafe, irritability, depression, anxiety, agitation. Following traumatic brain injury, it is not uncommon, in fact, it's more the norm than the exception, that an individual, as they're recovering and emerging from coma, will experience a period of agitation. In the rehabilitation world, this is a sign of positive, is a positive nature sign, in that we start to recognize that the individual is waking up and their brain is starting to react to the environment again. It can be extremely disturbing to family members to see their loved one cursing, becoming physically agitated and verbally agitated. So the need for a great deal of education regarding traumatic brain injury and the importance of moving through this period of agitation and how it will impact the continuation of hopefully successful outcome in regard to specific function. At this period in time, key in rehabilitation is managing safety of the individual, as they're typically not responding in a logical fashion. They are not thinking in a lucid way, and there's greater risk of secondary injury because they are agitated, impulsive, etc. Some of the physical signs, again, really dependent upon the significance of the injury, where the injury occurred, etc. One of the more common sequelae and issues to help manage initially in order to help progress the patient from a neurobehavioral, neurocognitive, and physical standpoint is managing the sleep-wake cycle. Again, more the norm than the exception that individual sleep-wake cycle will become reversed, and individuals with severe traumatic brain injuries will be more awake, impulsive, agitated through the evening hours, and then more somnolent during the daytime hours. So we look to manage that in a number of different ways. From an environmental standpoint, is during the day having shades up, having lights on. At night, trying to assist with a regular sleep schedule. At times, medications to assist with sleep at night, and possibly medications to assist with arousal during the day. Other physical issues which we address, headache, fatigue, vestibular dysfunction, motor dysfunction, visual impairments, which are extremely common following a traumatic brain injury, again, depending upon the severity of the injury and where the injury occurs in the brain. Some of the neurocognitive sequelae that we're addressing, as mentioned earlier, arousal and initiation, processing speed. Cognitive processing speed is a very common sequelae following traumatic brain injury, and assisting the family to recognize some of these things so that they're not overwhelming the individual. The mantra that I often use is less is more when it comes to a cognitive situation. And basically what that means is anytime you're in a situation of, should we turn the TV on? Less is more. At the early stages of recovery, individuals don't have the capacity typically to attend to the television. It's too much stimuli coming in and can lead to increased agitation. Memory, insight and awareness, again, another very significant neurocognitive issue that is impacted following a traumatic brain injury, and one that is addressed from an education standpoint and really trying to assist the individual in a very concrete way as to what's occurred, why they're in the hospital, especially in rehabilitation, and why we want to work with them and need them to work with us to assist in helping them to improve and get better. And then again, some of the neurocognitive sequelae associated with executive dysfunction, though, as we talked about before, while the frontal lobes, the prefrontal lobes are responsible for executive functions, and may be more specifically located there, again, the brain works in a very global fashion. So if information posteriorly isn't reaching the frontal lobes in the anterior portion of the brain, one may still experience significant executive dysfunction, though not having direct injury to the frontal or prefrontal cortex. Some of the neurobehavioral sequelae, as just mentioned, which is extremely important in the early stages of recovery. It will demonstrate that the brain is waking up as they're emerging from coma. Neurobehavioral sequelae, typically the early agitated phase people will move through. However, neurobehavioral issues unfortunately can be a long-term issue with a traumatic brain injury as well. So we talked about the agitation and impulsivity. As insight and awareness increases, more situational depression and anxiety often is seen. In a way, this is a positive in the sense that the individual is improving and getting better, improving from a cognitive standpoint, and can start to recognize the issues that are at hand, and thus one would expect that they're going to experience more anxiety and depression. At which point, though, because they're doing better cognitively, we can start to address that psychotherapeutically and in certain circumstances with medication as well. In the early stages of traumatic brain injury, depression, anxiety, frustration, anger, euphoria may be a direct physiological result of the traumatic brain injury and may be more in the moment, if you will. So typically with a traumatic brain injury, we'll experience kind of a two-pronged approach to some of the issues or emotional issues, those that are physiologically related to the specific traumatic brain injury itself. And then as the individual begins to improve neurocognitively, more of the situational issues that then we can address. Some of the somatic physical impairments, again, very much determined by the significance of the injury, as well as where the injury has occurred in the brain. So we may see motor dysfunction with paralysis, ataxia, apraxia, vestibular impairments, visual impairments, and as mentioned earlier, the sleep-wake cycle is often negatively impacted following a traumatic brain injury. Excuse me. So what is cognitive rehabilitation? We would like, in situations where an individual has suffered a traumatic brain injury, to have the ability, hopefully, to be stabilized during acute care and then move to an acute rehabilitation center, such as that in the Jefferson Health System here at McGee Rehabilitation. We provide rehabilitation to restore impaired neurocognitive skills and or to provide compensatory strategies to address those impairments. So initially, we want to identify the goals of the individual based on where they're at when they're arriving into acute rehab. Is the person oriented? Are they aroused? Are they arousable? Do they know who they are, where they are, etc.? And then we want to identify goals which are meaningful to the individual. So we want rehab and therapy to be about each specific individual. It's not a cookie cutter approach. It's clearly an individualized plan for each person based on their history, their present status, and their goals. Attention should be given to the awareness of those deficits, as we talked about just before, self-image and the emotional reaction and response. Again, those are issues that typically emerge as the individual is beginning to improve from a cognitive standpoint. We also want to monitor and improve the awareness of those things. So there's lots of different techniques. In addition, from a rehabilitation standpoint, individuals are involved with physical therapy, occupational therapy, speech therapy, recreation therapy, art therapy, music therapy, neuropsychology, psychological services, physical medicine and rehab docs, nursing, and a whole host of other team members that play a part both here within the hospital itself, as well as peer mentors and people who come from the outside to volunteer to assist in this recovery process. It is a marathon, not a sprint, in recovering from a traumatic brain injury, and that's something that's very important to address and discuss with families and the individual as they're ready and able from a cognitive standpoint to understand. There's lots of equipment to assist with the recovery, such as locomotor training, Rio body weight support bioness systems, help with electrical stimulation, etc., and recovery of movement and function. Environmental interventions are extremely important. Environmental strategies are aimed at developing and utilizing a set of environmental conditions to facilitate a patient's performance in rehab, in rehabilitation, return to work, school, socially, and or to avoid situations that will detract from their performance. So again, my mantra of less is more. One of the things that I think is very important to educate families about is looking at that environment. When the individual has downtime and is in their room, less is more. So not having a TV on, a radio on, 4 people in the room at a time, all of those things are going to be typically very extremely overwhelming to the individual, as their filter is really not working properly, and thus all of this visual and physical and auditory stimuli is rushing in, and it's extremely overwhelming to the person and can lead to increased agitation. So it's trying to minimize those external factors that could negatively impact recovery. And environment is something that we have some level of control over. So some of the medication considerations, I think typically my thoughts on medication is to recognize that we have an individual who is neurologically compromised. And medications are going to impact the neurological system that we may consider. So I think we want to be extremely judicious with medications in traumatic brain injury. That is not to say that they are not useful and that they should not be considered. I think it's just something that it's important to recognize, again, that it should be judicious in the sense that we, again, have an individual with an injury to their brain, and we have many medications that are then going to impact that neurological system. So one medication at a time, go low, go slow. The reason for one medication at a time, if we're altering too many neurologically based medications, if we do more than one, it's going to muddy the waters and make it very difficult to know what's helping and what's not helping. Obviously, starting at the lowest dose possible and moving slowly in regard to managing that medication, of titrating up if necessary. Dramatic results with traumatic brain injury are often seen with the withdrawal of certain medications, especially those sedating agents that people may be transferring from acute care hospitals into rehabilitation. During acute care stays, there are different focuses for the individual and different medications that can be used. So a patient who comes over on highly sedating medications and we withdraw those medications appropriately and titrate them down, we often see significant improvements in arousal and ability to participate. So it's just as important to look at medications which can be discontinued. Consider if medication is necessary, one medication which may have a dual treatment options. So a medication which may address depression and may address ability to increase appetite, for example, or a medication for sleep, which may also have some impact on depression as well. So thinking about that, if there's one medication which can be used as opposed to 2 medications. And then obviously be concerned about focusing on drug interactions and side effects related to medications. So with traumatic brain injury, there are no specific medications designated solely for traumatic brain injury. Typically, most of the medications are all off-label use. And again, as I mentioned earlier, we have neurologically compromised patients, so we want to be cautious as far as what we're using. So some of the medications and reasons for utilizing medications with traumatic brain injury. If an individual is struggling in their recovery to remain arousable or become arousable and assist with initiation, medications may be used to assist that. Again, looking at all of the behavioral interventions and environmental interventions that we can do, getting a regular sleep cycle, sleep-wake cycle, and maintaining consistency with all of those things. We may look at medications for attention and concentration if that's becoming problematic and we're not moving forward with that. May look at medication to help enhance language function. Bromocriptine has been shown to assist with expressive language. We may utilize medication to help with the sleep-wake cycle, to manage agitation, and to manage mood and affect. A thing, kind of going back to agitation again, is, as mentioned, agitation is typically a part of recovery. So sometimes we have to weather the storm, and rather than add medications, utilize safety measures, environmental measures, behavioral interventions to assist, rather than immediately turn to a medication which may slow the rate of recovery. So traumatic brain injury medications, just discussing a few different ones. Amantadine to assist with arousal, Ritalin to assist with focusing attention, bromocriptine I mentioned as a means of assisting both with arousal as well as with language functioning. To assist with sleep-wake cycle, trazodone, an example of, while it's not one of the more utilized or better antidepressants, it is an antidepressant, though it has sedation effects and assists with sleep. So that's an example of one of those medications that can manage or assist with two issues at once. Remeron as well. Other medications, Seroquel, Zyprexa, Abilify, assisting with agitation. Zoloft, Paxil, Cymbalta, Lexapro, etc. The antidepressant medications, sometimes, for example, something like an SSRI like Zoloft may be utilized to assist with initiation. But again, 2 for 1 in that it is an antidepressant and can assist with the emotional sequelae. Tegretol, propranolol for assisting as well with agitation. So it's a lot of information in a short period of time, just trying to highlight the significance of traumatic brain injuries, how often they occur, that they are a worldwide epidemic, that often don't receive the same level of acknowledgement as other diseases, illnesses, and disorders, but have such a huge impact on an individual's functioning, as well as that individual's social structure of family and friends impacting. One of the difficult things that I often see with traumatic brain injury is it's often an injury that, as an individual begins to recover and do well from a physical standpoint, as physical issues tend to resolve at a quicker pace than the cognitive issues, people will present and look as though nothing's ever happened to them, which can lead to some significant emotional sequelae. As someone is improving and getting better, as we mentioned, their insight and awareness gets better, and they start to recognize the things that they're struggling with. The people around them do not recognize those same issues because they look as though they did before their injury in many cases. So it can be an injury which is very difficult for people to see. It's not tangible to the outside world if the physical issues have resolved well. And yet the individual is struggling maybe with processing or attending to information, or being able to filter out lots of the additional stimuli that occur in the world. Brain injuries are something that people can make great improvement from with the right team, the right interventions, and it's important that from a global perspective, we recognize the significance of these injuries and that we can make a huge impact on individuals' lives and their families. So I appreciate your time. If there are any specific questions, again, I'm at the McGee Rehabilitation Hospital in Philadelphia, Pennsylvania. Email is todd.lewis, Lewis, at Jefferson, JEFFERSON.edu. And be happy to answer any questions or things if if you have any. So again, thank you for your time. I thank Philadelphia International Medicine for inviting me to lecture today, and have a good day.